This is Mary Ellen Schneider reporting for Global Medical News at the American Academy of Family Physicians Scientific Assembly in Boston. I'm speaking with Dr. Caryl Heaton, the Vice Chair of Family Medicine at the University of Medicine and Dentistry of New Jersey. Dr. Heaton has presented an overview of the patient-centered medical home concept.
There's a number of ways to define the medical home. I think the definition I like the best is the definition that says the medical home is traditional family medicine that's merged with 21st century technology and 21st century processes. Another definition I like is just the learning, improving practice, a practice that takes what it's doing and constantly tries to learn from it, to be more effective, to be relationship-centered, not just patient-centered, but centered on relationships. And my last definition that I like is basically that it's a physical location where a team of professionals work to get patients the care they want and need when they want and need it. That's a big order, but that's what we're shooting for, and it's an ideal, it's a goal, it's a symbol of what we can do with improved primary care.
What are the first steps that family physicians can take to start a medical home in their practice?
The first thing I urge is a practice to have regular weekly meetings. The National Demonstration Project found out that lots of practices actually don't get together that often, or that they have sort of two cultures in a practice. One is the culture of the staff, and they meet on their own, or that the physicians meet on their own. I'm suggesting that we get together for weekly meetings, and you ask your team, you ask your staff what kind of things you need to improve. They will know. If you have no other starting place, then just think about your flow, your workflow in terms of refills, in terms of labs, in terms of referral tracking, and in terms of getting patients in when they need to be seen. Those are great topics to start with.
Can physicians really get paid to do this? And how much money are we really talking about?
Well, the simple answer to that is I don't know. I don't know how much money we're talking about. I do know that there's 91 demonstration projects approximately in the United States. So there's a number of demonstration projects where they're looking at the concept of the medical home. Not all of those involve more money, but many of them do. And the variety of payment goes from $2.50 per patient per month up to $15 per person per month or more. That may not sound like a lot of money, but for a start, that could really help to ease the bottom line. I wish I knew more about how to get paid for it. As we kind of stick together in terms of doing this and say, well, we're doing more, so let's get paid not only for face-to-face visits, but also for care coordination, maybe add in some sort of payment for reaching targets, such as pay for performance. But primarily, we want the pie to get larger, not just to be divided up differently. So I think that we need to work with our academy, with our state groups, and with our quality improvement groups to try to get better paid. And I wish I could tell you that there was a certain dollar sign. I do think that it's in the thousands of dollars, not the hundreds of thousands of dollars, but we'll keep working at it.
This is Mary Ellen Schneider with Global Medical News at the AAFP meeting in Boston.